So I want to talk today about biases in allocation of COVID-19 relief funding. This is a joint work with Pragya Kakani, who's a PhD student at Harvard, Ziad Obermeyer, and Amitabh Chandra. Ziad's a faculty member at Berkeley, and Amitabh's a faculty member at Harvard. So what I want to do today is to talk about one paper, which is a very short paper we had in JAMA that came out. It was part of this exciting period that kind of, given tragic circumstances, but I think really changed the way a lot of social scientists do research. Like, we felt like COVID is happening. Wow, like I want to contribute to doing something about this activity. And that is what motivated this paper, as motivated many other people. So what I want to tell you is the problem we were dealing with. So the issue was, goes back to right around the time at the beginning of the virus, and we were worried about hospitals being overloaded, et cetera. People quickly realized, wait, there's kind of a problem here. Like, there's a healthcare problem, but there's actually a pure financial problem, which is hospitals are about to be slammed. They're about to take massive financial hits. And what are we going to do about that? I found this New York Times headline particularly cutting. Hospitals knew how to make money, then coronavirus happened. And the forecasts were very large. We are talking about hundreds of billions of dollars. And as those of you working in corporate finance might know, these are not just transfers from, hospital, deep pockets of hospitals to something else. These risk genuine financial distress and hospitals shutting down. And if we don't do something, we could actually face far fewer hospitals and sort of lots of fixed costs gone. Okay. But the government tried to do something about this. This is an example of the CARES Provider Relief Fund. The idea was, well, we've got this problem with COVID. The way we're going to try and do this is we're going to support the impact that COVID had, the fiscal impact, by transferring $175 billion. The question is, how should those $175 billion be allocated? Now, where do we want it to go? We want it to go to the health systems most affected by COVID. Specifically, the health systems are, most revenue lost due to COVID. So that the delta in impact from COVID. So the question we're interested in is, how equitably will these resources be allocated, and in particular, racial disparities in this? So, because anytime we allocate resources, we worry about inequities. And along the way, I'm actually going to talk a little bit about the efficiency of this allocation. Now, a lot of us who were motivated to do something about COVID, I think it's fair to say the right stepping off point for all of us is not just the question of interest, but what we knew anything about. And we had done a little bit of work and had seen problems like this before. And what the kind of problem I want to talk about is the targeting of resources is a prediction problem. That we're trying to predict the COVID burden, predict the revenue shortfall. And in fact, we'd seen exactly this kind of problem in a paper that we just finished that had come out in Science on racial bias in an algorithm. And I'm going to walk you through this paper briefly, because I think it'll be very useful to see the analogies between this paper and what we find for the CARES allocation data. Because in part, I think it'll tell us both something about COVID and about how we ought to be allocating these resources in the future. So let me tell you this brief side note about this paper. Allocation of care coordination programs is what this paper dealt with. So the idea, for those of you who don't know healthcare, is that patients with a ton of chronic diseases are the source of the biggest costs in healthcare. So programs were like, wow, we want to help these patients out because they're the ones who are going to be the biggest cost. So for example, if we give them a nurse who they can call before coming in, then they don't need to come in and clog up the system. Maybe there's some things that could just be dealt with by a nurse. So sort of focus resources so these people can more efficiently use and seek care. Now, these programs are expensive, so targeting is crucial. In fact, the question is, how do we target care coordination program to patients? And you'll notice this looks exactly like how do we target CARES resources to hospitals. Now, in the coordination programs, there was already an algorithm, a rule used to target these patients at scale. So this algorithm had been running for several years. These algorithms had been running for several years, implying about 100 million patients. So what we looked at in this older paper was, how does this algorithm do? And I want to take that and ask what lessons for the rules used by that algorithm are there for the CARES Act. So just to remind you, this is what the distribution of patients would look like by sickness. And this is the algorithm risk score. So what is an algorithm? It's just a rule for scoring. And this algorithm is going to determine who gets treatment. So the top 2 to 3% would get auto-enrolled in a care coordination program. The next 45% would get enrolled as a function of something. And the bottom 55 are screened out. So what we were interested in is, okay, you have this algorithm deciding who gets these programs. How much racial bias was there in this algorithm? So what do we mean by racial bias? We mean at the same score, people should be treated the same and they should have the same needs. So the color of their skin should not matter. And here's what we find. On the x-axis is the percentile of the risk score. On the y-axis is how many active chronic conditions that people ended up having, the realized conditions. And you'll notice at the same score, white patients in the bottom curve are far less sick than Black patients. And this gap is enormous. There are 28% more chronic illnesses at the auto-enrollment threshold, but that's a little hard to interpret. So let me instead point out to you, we have 18% Blacks enrolled right now in the program. If we just equalize these two curves, we'd have 47% Blacks enrolled. That gap is that big. And you can kind of read out by looking at the marginal white patient. Look how much you would have to go across the curve to get to the marginal Black patient to be equally sick. So what was happening in this program? So what's happening in this program is that the algorithm, to understand where it went wrong, you kind of want to get a clue as to where it's going right. If I redid the same exercise, not for health, but for costs, you'll find the algorithm is remarkably well calibrated for costs. Instead of finding the patients who are going to be the sickest, we found the patients who are going to be most costly. Being biased in health and unbiased in cost is what we managed to accomplish, because Blacks and whites do not have the same relation between health status and costs. Whites have better access to healthcare. As a result, at every level of health, Blacks cost less. So if you go about targeting costs, you get biased health prediction. So the depth of the problem is that so basic that this isn't some trade-off. Oh, maybe I really care about cost. If you knew you cared about cost and health, you can actually do well at predicting an algorithm that does nearly as well at predicting cost, but has no racial bias and predicts health better. And that's because when you build these algorithms, you can imagine it's a flat of the curve. I kind of roughly optimized for one variable. Had I known I cared about two variables, I would have actually found a solution that was almost as good for the first one, but did really well on the second one. So there's approximate money on the table, even if you really just cared about cost. So the key takeaway is in targeting, getting the exact measure to be predicted matters. I think this is a cousin of Goodhart's law, you know, how a target becomes a measure, it becomes useless. Here, we often end up predicting the target we have, not the target we want. In this example, the coda, the postscript, is that actually people, when they saw this paper, they're like, holy cow, what are we doing? So they started trying to fix the problem. It's just, we did this through convenience. Now you can imagine where we're going to go. Let's go to the CARES funding allocation. How was the first round allocated? It was allocated to the hospitals based on their revenue in the past. Now, the second round took a few other things into account, like safety nets and rural providers, but it ultimately, conditional on those, the variable at play was net revenue. Now, that's a little funny because the desired target was hospitals who will have high needs due to COVID. What was used was that the systems who used a lot of resources in the past. Resource intensity is not the same as resource need, especially not resource need due to COVID. And you'll see the analogy is perfect here. And that's why we started working on this problem. So what do we find? Well, first, obviously, the revenue that systems got after the revenue that systems realized was highly correlated with the CARES Act fund per resident. So on the x-axis is how much funding did you get? On the y-axis is what was your realized revenue for the following quarter. And you'll see that, in fact, there is a strong correlation. Okay. But let's show you how different that correlation is than where COVID actually hit and where the burden was. So the top is where this first figure is where the money went. And the second figure is where COVID actually hit. And you can see this is not really such a difference. Now, you may say, oh, is this just about like COVID was hard to predict? Actually, that isn't it, because these are the comorbidities on the bottom map. So it's not where COVID hit, it's where COVID would have the biggest consequences based purely on ex-ante comorbidity. We could have chosen the second figure, but we kind of ended up choosing the first one. Let me show you how off the correlations are on a bunch of other things. Revenue correlates very well, but the chronic illness prevalence, hospital financial health, which you thought we would have cared about, didn't matter, and certainly COVID-19 cases and deaths don't matter. Now, this is just a bad targeting rule, but as the racial bias paper told us, because it's focused on revenue, it could have a racial bias component, which is what we looked at next. On the x-axis is the CARES funding yet again, and on the y-axis is the COVID deaths per 100K. And now you'll see, conditional on the funding, there were far more deaths in the counties that were highly Black than in the counties that were highly white. So this is very similar to the graph I just showed you. It's just racial makeup of county. What this is telling you is, if you went to counties that had $800 funding per resident, the white counties had far fewer COVID deaths than the Black counties, like by a wide margin. And you see this not just for COVID deaths, you see this for comorbidity, you see this for each of the elements, including something as simple as hospital cash on hand or hospital operating margin. There was always a disparity. This is a regression, which in the interest of time, I'll skip, but this is in the paper, just everything I showed you in regression format. So what do I want you to take away from this? Well, I think the money missed the intended target. And we know this a little bit now in the last few months. Some places, a little bit ashamed, are giving back the cash. They're like, well, we're making a lot of money. This feels a little weird that we're putting high operating revenue on and we took money from the government. But more importantly, the money exacerbated large racial inequities that we already know were occurring due to COVID. And I worry that we're going to leave a scar, that hospitals serving Black communities may take longer to recover, or some may even frankly shut down. So this effect is not simply, oh, we made a mistake. This mistake may persist. We're about to allocate $35 billion now in this new bill. Are we going to make the same mistake again with this $35 billion? I would hope not. But this isn't a mistake. It's an entirely preventable mistake. You could say the financial burden of COVID is hard to predict. Yes, completely agree. But better modeling could easily have been done. We could have targeted the policy to needs, not to revenue. That's complicated, but we have a lot of data that could have been used. Again, this is not about predicting the spread of disease. This is not an epidemiological thing. This is about recognizing comorbidities, financial health of the hospital. Various things could have all been used to predict the distress that a hospital would face. I think I want to end on a more general point. I think the empirical policy toolkit is highly advanced. That's the amazing thing that economists have contributed to and driven over the last 50 years. But predictive modeling is not yet a big part of it. And I think as these things show allocation of resources, where money should go, so many choices are about predictions that we're implicitly making. And I think if we took what we are starting to understand about that and could import into the toolkit, we could prevent what I think is a disaster like this. All right, thank you.